Good afternoon. My name is Luke. I'm one of the urology residents at the University of Nebraska Medical Center. I'm the moderator for this talk. And without further ado, I'd like to introduce Dr. Makari.
Hi, good afternoon, good evening, different points of the day for different people that are watching. Probably not good morning, but maybe. Nice to see you all remotely through Zoom. I'm sure that we are all doing a lot of this through our own practices and are very familiar with the Zoom format, so it's becoming very comfortable. So for those of you who don't know me, my name is John Makari. I'm the Chief of Pediatric Urology at Children's Hospital and Medical Center in Omaha, Nebraska, as well as at the University of Nebraska Medical Center here in Omaha as well. Just by way of background, I went to the Ohio State University for my undergraduate, graduate school, and medical school training, and then I went to Washington, D.C. and did my residency at the George Washington University. Spent a year doing pediatric urology there at Children's National Medical Center as a resident before doing my fellowship at Vanderbilt Children's Hospital in Nashville, Tennessee. I practiced in Connecticut for about 10 years, and I've been here for just over 2.5 years. Apologies for my appearance. I think appearance is probably okay and overlooked at this point with COVID, but most of the day today I was wearing my mask. Unfortunately, last night I got to experience being a father of a patient. My 16-year-old daughter had appendicitis. So at 7 o'clock this morning, she had a laparoscopic appendectomy. She's doing very well. She went home from the hospital quickly thereafter, but it was an interesting experience to be able to be on the other side of healthcare. Doesn't have anything to do with this talk necessarily, but it did kind of open my eyes a little bit to what some of our patients go through. Had a great experience. She did very well, but I can imagine how the stresses of providing care for a child long term could really take a toll on parents. So it was an eye-opening experience and good. I think it also helped my daughter see why I spend so many hours away from being home at times, because things don't move as quickly as we'd like to see sometimes. So it was a eye-opening experience for everybody. But without further ado, I want to talk a little bit about posterior urethral valve. Dr. Kopp did a nice presentation previously about antenatal intervention for lower urinary tract obstruction. And going to kind of talk a little bit about that in this talk, but this is really an overview of posterior urethral valve. There will be a Q&A session at the end of the talk today, and Dr. Wang is going to help facilitate that. So we will make sure that we leave plenty of time for that at the end of the procedure. The end of the talk. I'm just going to get my phone so I keep an eye on the time. So I have no disclosures either with respect to anything I'm talking about today or in general. I'm not going to be talking about any unapproved or investigative use of any kind of product or device in my presentation. So posterior urethral valve is a diagnosis that affects male patients. The incidence has been estimated to be between 1.6 and 2.1 in 10,000 live births. So that's roughly between 1 in 5,000 and 1 in 8,000 births. Obstructive uropathy, as you all know, is the most common cause of end-stage renal disease in children. 16.3% of transplant patients, in fact, are from obstructive uropathy, and posterior urethral valve is the most common cause of fetal lower urinary tract obstruction. Morbidity from posterior urethral valve is highly variable. So some patients have a significant impairment in their renal function, while others do very well. We'll talk a little bit later about pathophysiology, between the differences between the irreversible and potentially modifiable injury and impact on the renal function. Posterior urethral valve has the potential to impact pulmonary development with oligohydramnios or anhydramnios can lead to poor or no pulmonary development. And long-term, both renal and lower urinary tract dysfunction can develop in these patients. Up to half of our patients that we care for with posterior urethral valve will develop end-stage renal disease. There's really not been any intervention in the last 20 years that has changed that, unfortunately. But hopefully with continued advances, continued investigation into this disease, and continued technological and surgical advancements, hopefully we can impact that in our lifetime. So the earliest mention of posterior urethral valve occurred actually in 1802, so really 200 years ago. Second reference occurred 30 years later, and it was observed that some patients had valve-like folds in the posterior urethra. It was thought to be of clinical significance, but not understood completely. It was not until 1870 that the first comprehensive description and recognition of the pathologic nature of these posterior urethral valves took place. And then Hugh Hampton Young really developed a classification system through observation in his own patients of what we now use to describe posterior urethral valve. He initially in 1912 described a 17-year-old male presenting with urinary difficulty since birth. On exam, he was noted to have residual urine, pyuria. He underwent urethroscopy, which showed two thin valves springing from the crista urethralis. And he was diagnosed with congenital valves in the posterior urethra, and that's kind of the etiology of this nomenclature. He was treated with rupture of valves per urethram with a urethroskope. He survived until a year later when he succumbed to pneumonia. In 1919, so 7 years later, Hugh Hampton Young reported a series of 9 patients with congenital obstruction of the posterior urethra and classified those by 3 different types based on his observations. He subsequently reviewed the literature at that time and found an additional 17 patients with similar descriptions. As you all know, he described 3 types of posterior urethral valve. We really describe posterior urethral valve as type 1 or type 3 at this point, knowing that type 2 is not an obstructive valve. Again, the most common type of posterior urethral valve is the type 1 posterior urethral valve. It is a situation in which there is abnormal tissue in continuity with the vira montanum, and it takes kind of an anterior course and divides in the region of the bulbomembranous junction. These tissues generally have fusion except at the anterior portion, which is not a complete fusion. There's a point of slight separation in the posterior urethral valves. In some patients, they will have complete fusion of the anterior portion of this. There's a representative picture of type 1 posterior urethral valve. Type 2 posterior urethral valve arises from the vira montanum, extends towards the bladder neck along the posterior urethral wall, but it's really not an obstructive phenomenon. So in our modern nomenclature, we typically classify as type 1 or type 3 posterior urethral valve. Type 3 posterior urethral valve, rather than being individual leaflets, is an annular configuration of tissue causing obstruction. There's really no relationship between the type 3 posterior urethral valve and the vira montanum. It can occur at different levels of the posterior urethra. And so this is what some people will describe as an annular or crescent, more of an kind of an annular crescentric obstruction. So in 1929, 10 years later, Hugh Hampton Young reported an additional 12 patients. So in his series, a total of 21 with congenital obstruction of the posterior urethra, 8 of whom were examined endoscopically. And the next major advance in description of posterior urethral valve occurred with Dr. Hardy Hendren, who in 1971 described this, that posterior urethral valve really represents a spectrum of disease. And we know that from our patients that we care for, that some patients will have significant sequelae from their posterior urethral valve, while others have a relatively normal voiding function and relatively normal renal function. Just as we notice there's a clinical presentation, there's also, or excuse me, a clinical spectrum of presentation, there's also a clinical spectrum of the extent of the valve tissue. In 1992, Dewan and colleagues proposed a different terminology, congenital obstructing posterior urethral membrane, or copum, and that may be a better description of what this tissue really is, but we classically use Hugh Hampton Young's classification most widely. So the etiology of posterior urethral valve is not completely understood. The inheritance pattern is poorly understood, but it has been recognized that it can occur with increased incidence in siblings, twins, and successive generations. It's believed that the obstruction occurs during the period of urethral development, during or after the 8th week of fetal life. Prenatally, the pathophysiology of lower urinary tract obstruction involves injury of the developing urinary tract. The obstruction can lead to oligohydramnios, which then in turn can lead to pulmonary hypoplasia, which is a major cause of mortality in posterior urethral valve, and the most severe manifestation of this is Potter sequence. So again, it's felt that the injury occurs to the entire urinary tract above the level of obstruction. That occurs from the dilated posterior urethra to a hypertrophied bladder neck, extending up into the upper urinary tract as well. Within the bladder, we'll see a hostile, trabeculated, thick-walled bladder that can have variable degrees of collagen composition, which with increasing collagen composition leads to decreasing compliance. Hydroureteral nephrosis can be quite severe in these patients, and that in turn leads to poor ureteral function with respect to with poor peristalsis of the ureters and leads to urinary stasis, which increases the risk of urinary tract infection. So renal injury itself is really classified in two different components, one of which is dysplasia, that's irreversible. Unfortunately, that's the primary determinant of renal function. So that references the extent to which the renal parenchyma develops abnormally. And the other component of renal injury relies on obstruction. That's potentially modifiable. It relates to glomerular and tubular injury from failure to concentrate and acidify the urine, and then polyuria, which stresses the urinary tract. The vast majority of posterior urethral valve is diagnosed prenatally these days. However, there are patients who are diagnosed later in life, often with voiding symptoms, urinary incontinence, urinary tract infections. The later presentation, understandably, is often associated with a milder phenotype and less impact in terms of function. Prenatally, the transition of fetal urine as the primary constituent of amniotic fluid occurs at around 16 weeks. This is a period during rapid renal development, and it is a critical period to consider intervention. I'm not going to go into antenatal intervention in too much detail, as Dr. Kopp did that before, but this is something that's often can be seen during the first anatomic survey, which typically occurs in the second trimester between 18 and 22 weeks. Ultrasound is actually fairly accurate in terms of making this diagnosis. Sensitivity is up to 94%, but specificity, unfortunately, is low. It can be as low as 43%. Bladder distension and wall thickening are important indicators of lower urinary tract obstruction. So signs that we might see prenatally of lower urinary tract obstruction would first of all be male gender. Secondarily, hydronephrosis and hydroureter. So this is a hydronephrotic kidney with thin renal parenchyma and a ureter that is significantly distended and tortuous. Megacystis or enlargement of the bladder. This is a fairly classic keyhole sign here. So if you turn this 90 degrees counterclockwise, it looks like an old skeleton keyhole. For those of you who've never seen that before, this is what we're referring to for keyhole sign. Oligohydramnia, so decreased amniotic fluid, especially if it was previously normal and is not at a point where you'd expect rupture of membranes. And then urinary ascites or urinary ascites or urinoma can be observed prenatally as well. There are some quote-unquote pop-off mechanisms or things that may help to decompress parts of the urinary tract. Urinoma can be seen in these patients, so urine collection around the kidney actually decreases the pressure within the kidney. So this is urinoma outside of Gerota's, or excuse me, inside of Gerota's fascia, but outside of the renal capsule where there's fornicele rupture. 40% of fetal ascites is actually due to urinary conditions. So it's something we need to think about in fetuses that have ascites. So the VURD or VURD syndrome is a syndrome that's been described as valve, unilateral reflux, and dysplasia. So in that situation, it's felt that one kidney and one kind of drainage component or upper tract takes the hit, if you will, of the obstructive uropathy. And so by one side refluxing, potentially leading to fornicele rupture and urinary ascites, that can theoretically decompress and preserve a more normal contralateral kidney. And bladder diverticuli can also serve as pop-off mechanisms. So those are weaker points that can serve to provide some decompression of the lower urinary tract. When we're seeing these kinds of findings prenatally, we have to obviously think about a differential diagnosis. Most common things we think of would be posterior urethral valve, urethral atresia, prune belly syndrome. Less common, but can produce similar findings, would be anterior urethral valve or diverticulum, which is, I'm not going to talk about it too much in this lecture, but essentially it's a situation in which a diverticulum has a leading edge that leads to obstruction of the urethra. In the absence of additional tissue, it's related to a defect in the ventral surface of the urethra. Congenital megalourethra, as can be seen with Eagle-Barrett syndrome, obstructing ureterocele. So ureterocele can be so large that it can obstruct the bladder neck and the bladder outlet. There's some other rare conditions that mimic posterior urethral valve. One can have megacystis megaureter syndrome, in which urine refluxes into the upper urinary tracts during voiding, and then fills the bladder after voiding to a point where the bladder starts with some degree of fullness that over time leads to gradual distension of the bladder. Isolated megacystis is fairly rare, and then megacystis microcolon intestinal hypoplasia syndrome can cause findings similar to posterior urethral valve. So in terms of newborn evaluation and management, and this can vary by institution, it varies by resources that are available in different locations. I'll talk a little bit about my institution and institutions that I have practiced at, but typically posterior urethral valve is managed in our neonatal intensive care unit. The first step in management, wherever that's done, is a bladder decompression. So being able to decompress the bladder really removes urgency of intervention by bypassing the obstructive tissue. That can be done either with an 8 French feeding tube, 5 French feeding tube. We typically recommend using a feeding tube or a non-balloon catheter to drain the bladder, or at least not inflating a balloon of a Foley catheter, because that balloon with a very hyperdynamic bladder can lead to contraction of the bladder around the balloon, which can then lead to obstruction of the ureteral orifices and defeat the purpose of bladder drainage. So we typically use a non-balloon catheter. We typically will obtain a renal bladder sonogram. We like to do that after a catheter is placed. If we're not sure of the diagnosis, obviously we'll do a renal bladder sonogram beforehand, but if we're placing a catheter with presumed lower urinary tract obstruction, we like to do a catheter perform an ultrasound after the catheter is placed so that we can confirm good decompression of the bladder. And then in our institution, we manage these patients collaboratively through our neonatal intensive care intensivists, urology, and nephrology. We like to do as much prenatal consultation and counseling as possible, but sometimes these diagnoses are surprises to patients. We typically will place our patients on prophylaxis. We typically use amoxicillin. We typically get daily or twice daily chemistries and creatinine, depending on the severity of their renal dysfunction. And then once they're stable, we'll get a voiding cystourethrogram to confirm the diagnosis, but we treat them as though they have a valve if they're prenatal indicators until it's proven otherwise. So just for comparison, because we have different levels of learners watching these videos. So voiding cystourethrogram pictured on the right is a normal voiding cystourethrogram. This is a smooth-walled bladder, a normal caliber urethra without substantial transition from the posterior urethra to the anterior urethra. And there's no evidence of vesicoureteral reflux. Just for orientation, this picture actually came from one of my fellows, Trey Smith, who's practicing in Hershey, Pennsylvania right now. So I credit him with this, but this kind of describes the prostate and the relationship of the posterior urethra. And so that kind of corresponds here. So patient that has posterior urethral valve will have a dilated posterior urethra with a clear transition point, as classically, to the anterior urethra, which is much thinner. You'll see a very trabeculated, potentially bladder with potentially diverticula and or cellules and varying degrees of reflux. The patient obviously has severe reflux. In terms of management, we'll talk about options shortly, but the kind of standard of care for these patients involves valve ablation. The timing of that intervention depends on a couple of things. First of all, they need to be stable for the OR. As long as they have a catheter in, there's no rush to get the valve ablated other than the goal of getting the catheter out and reducing associated iatrogenic urinary tract infections. There are different schools of thought as to the optimal timing of valve ablation with respect to creatinine nadir. Some pediatric urologists prefer to perform valve ablation as soon as the patient's stable, get the catheter out of them and kind of see how they do. Others like to wait until the creatinine demonstrates some degree of nadir so that when the catheter is removed after valve ablation or after the patient's no longer catheterized, they have a sense of whether or not the bladder is contributing to worsening or improving renal function, or whether the valve or residual tissue is. That's a, there's good arguments on either side. And even within same practices, some people will do this differently. So catheter is typically removed shortly after valve ablation, day after, 2 days afterwards, once urine output's demonstrated to be stable. So some other considerations in early valve management include urinary diversion. So in patients, there are some indications for performing a cutaneous vesicostomy. This is a reasonable temporizing measure in small infants, perhaps ones in whom a scope is difficult to navigate their small urethra if they're premature. I'm going to show a video later of a premature baby in whom we performed valve ablation with a 3 French hook electrode, which isn't the standard resectoscope, but there are ways either with a small hook blade or whether using laser to ablate valves. But some patients who can't be instrumented, performing vesicostomy is a reasonable temporizing measure. We know from extensive studies that it really doesn't ultimately impact bladder capacity long-term or bladder function, but primary valve ablation is a preferred intervention. Upper tract diversion is rarely necessary, but in some situations there's obstruction despite relieving the valve tissue that's occurred from bladder neck hypertrophy. Bladder hypertrophy or of isolated or separate pathology that leads to obstruction. Doesn't improve long-term outcomes, and so again, treating the valve is the main consideration. Consideration could be given to performing upper tract diversion if creatinine remains elevated after 10 days of adequate bladder decompression, if there's unchanged or worsened hydronephrosis or hydroureteronephrosis. Other things to consider in valve management, that urinoma and urinary ascites is seen in 9 to 15% of patients with posterior urethral valve. These are good pictures. One is on a MRI, fetal MRI. The other is on a voiding cystourethrogram, where urine is actually extravasating outside of the kidney. So you can see it in the arrows here. Some of these really good pictures are from my former fellow, Dr. Trey Smith, so I'll give them credit along the way. In terms of the impact of long-term renal function, it's unclear whether urinary ascites or urinoma has any bearing. We typically don't recommend treatment unless it's increasing in size, creatinine's rising, there's infection, patients having hypertension from extra renal compression, so in that circumstance, so those are kind of intertwined. We typically manage patients in conjunction with our nephrology colleagues, and close follow-up is required after discharge from the hospital. Many children have very high-grade reflux and stasis of their upper urinary tract, so we in our institution typically recommend urinary prophylaxis. We typically perform serial renal bladder sonography to determine the impact of valve ablation. Plus minus voiding cystourethrogram 6 weeks afterwards, and then baseline urodynamics somewhere on the order of about 6 months to give the bladder time to kind of recover and develop as it's going to. So long-term management is critical for these patients. Having the effect of posterior urethral valve is really a lifelong problem. It can lead to valve bladder. Our goals are initially preservation of renal function, preventing urinary tract infection, and then long-term developing urinary continence. And much as neurogenic bladder can impact these domains, posterior urethral valve and valve bladder can, in different ways, affect these same goals. Valve bladder is the product of chronic bladder dysfunction. It can occur despite successful valve ablation, so it's important that families be counseled that just treating the posterior urethral valve doesn't solve all the problems that are related to this impact. Upper tract deterioration can progress from having valve bladder, and incontinence can be quite frequently seen in patients. In the 90s, Churchill estimated that only about 50% of patients by the age of 12 are completely dry day and night. Reflux is typically treated by managing the bladder well. It's typically secondary reflux, and the primary management realm is of treating a reflux. So valve bladder evolves initially from polyuria that ultimately is confounded by the fact that urine is stored in the upper tracts and then drains into the bladder after voiding. So that plus polyuria leads to increased post-void residual. It leads to increased stretch in the bladder, and then leads to collagen and filament changes in the bladder. Those in turn lead to bladder wall hypoxia and increased storage pressures. Those pressures are ultimately transmitted up into the renal pelvis and renal tubules. That then promulgates polyuria due to renal concentrating defect, and leads to attempting to void at increased pressures, which then drives urine up into the upper tract, leading to an increased post-void residual, and it's a vicious cycle. So this polyuria, coupled with poor bladder compliance and high pressure, leading to residual urine volume, make the cycle continue. So urodynamics and valve bladder typically provide important information about bladder function, as they do in other diagnoses. Serial urodynamics can provide insight into the progression of one's bladder function. There are typically 3 described stages of bladder function in patients that have posterior urethral valve, and these are, the length of time or the manifestation of each of these is different in different patients. Again, it's a spectrum of diagnosis, but the kind of hallmark of stages of bladder progression in posterior urethral valve include detrusor hyperreflexia in infancy and early childhood, leading to decreased intravesical pressures and improved compliance during later childhood, and then ultimately increased bladder capacity with hypocontractility and atony in early adolescence and later adolescence. So management of bowel bladder is really trying to mitigate the effects of that cycle that we saw. So that can be achieved through attempting to limit detrusor overactivity and tackling compliance with anticholinergic medications. Myogenic failure can be addressed through time-voiding alpha blockers to help improve emptying, clean intermittent catheterization to help emptying, overnight catheter drainage to both impact emptying, distension of the upper urinary tract, and the polyuric effects. Again, polyuria complicates management of all of these because any of these interventions can be made more difficult and less easy to comply with in the case of more urine output. Refractory patients ultimately at times require augmentation cystoplasty or incontinent urinary diversions. So what's the prognosis for these patients? Up to 50% of these patients, as we mentioned, will reach end-stage renal disease. Obstructive uropathy is the most common most common cause of end-stage renal disease in children, with up to 16.3% of them presenting for transplantation. Of patients presenting for transplantation, 16.3% of them are secondary to obstructive uropathy. Nadir creatinine, so defined as the lowest creatinine achieved during the first year of life, less than or equal to 0.8, has a good prognostic benefit for long-term renal function, whereas a nadir creatinine that's greater than 1.2 at age 1 predicts a high risk of end-stage renal disease. It's important to carefully study and optimize the abnormal urinary tract prior to transplantation. So those patients that do progress towards transplant, if they have poorly managed receptacle for storage of urine, are likely to lead to transplant failure. So that involves urodynamic evaluation, assessment of emptying, potentially surgical intervention to decrease pressures and increase capacity through augmentation cystoplasty and or clean intermittent catheterization. But it's critical that those interventions lead to a well-managed bladder prior to transplant. It's an entirely different talk, and there's a lot of literature that looks at the benefit of preemptive versus concurrent augmentation cystoplasty. Our institution's preference is towards preemptive augmentation cystoplasty for patients that are expected to undergo renal transplantation, but there are arguments on both sides, and so again, beyond the scope of this talk today. Surgical treatment of posterior urethral valve, again, we talked about endoscopic valve ablation. We'll talk a little bit about that history. So he, Hampton, and Young proposed resection of that through an open approach. Later, open ablation was accomplished with long-term suprapubic catheter drainage. Unfortunately, that was complicated by incontinence, stones, infection. Supravesical diversion, either with ureterostomy or pilostomy, was advocated in the 60s. That afforded drainage without tubes. It was thought to be temporary, and there was belief that that might lead to better bladder function long-term. Hardy-Hendren described in 1970 a report of concerns of incomplete drainage of the upper tract with ureterostomies alone. And in 1972, it was argued against supravesical diversion. Temporary defunctionalization was thought to induce irreversible hypercontractility of the bladder. And then Tanaga reported similar permanent contraction of the bladder as a result. Barry Bellman and Lowell King described in 1972 vesicostomy as a useful means of reversible urinary diversion in selected infants. That procedure is well known to many, but essentially it involves bringing the dome of the bladder up to an incision on the lower abdomen in the suprapubic area. Potential complications of this include prolapse, stenosis most commonly. There are a number of different supravesical diversions that have been described. End cutaneous ureterostomy, loop cutaneous ureterostomy, either high or low, sober YV. There are a number of different diversions. Again, Hendren reported no significant long-term outcome for renal function with supravesical diversion, not just bladder function. In the 1980s, long-term renal function and somatic growth was purported to be beneficial. So there was a resurgence of supravesical diversion in the 1990s for preservation of renal function. About that time, John Duckett started to report data similar to Hardy-Hendren's that suggested no protective effect. Many studies then corroborated that observation, and recent data suggests better bladder function with early endoscopic valve ablation over upper urinary tract diversion. So that's kind of a pendulum that's gone back and forth, and we see that in a lot of areas of medicine. Posterior urethral valve is no exception. Transurethral disruption of valve was described in the early 80s, or excuse me, the late 80s, as early as the late 80s. That could be either through a blind technique or fluoroscopic technique, either with sharp instruments, balloons, a number of different things, but the goal was ablating the valve. As endoscopes became better, endoscopic valve ablation became really the gold standard. That started as early as 1966. That has been described as being done with a hook or a cold knife, bug bee electrode, laser, as we talked about before, or even performing an antegrade incision. This is kind of a video, again, this is a neonate that was born prematurely, gestational age of 32 weeks, that had reasonable creatinine and was stable to go to the operating room. And so an effort to remove the catheter in this patient, valve ablation was performed early. This is, for those who haven't seen it, this is a pretty typical valve bladder at birth. This demonstrates the really dilated posterior urethra, the vira montanums, in the middle portion of the screen there. And you can see this classic, what type of valve is that? Type 1 posterior urethral valve. This again is not our preferred intervention. We prefer to use a resectoscope, either with a hook electrode or cold knife. Some prefer laser. And again, there can be differences in practice, but this just demonstrates valve ablation in a young neonate with a 5 French cystoscope and a 3 French hook electrode. So with improving instrumentation, more is possible. And that's likely the genesis of some of the future interventions for antenatal intervention. So end product of this valve ablation is a wide open valve. We like to look in the tissue adjacent to the viru to make sure that we've resected all the way down to the floor. And then making an anterior 12 o'clock incision as well. So in addition, we know that circumcision has a protective effect with respect to reduction in the rate of urinary tract infection. We recommend circumcision to patients with posterior urethral valve and typically perform it concurrently with valve ablation. Nephroureterectomy was previously thought to be appropriate for most patients that had the Verge syndrome. Some people prefer to preserve the ureter with nephrectomy alone for use in later reconstruction. Again, the nephrectomy portion of that is designed to reduce the polyuric effect on the upper tract. in a poorly functioning kidney that doesn't concentrate urine well. Antenatal intervention, again, I'm not going to go into this too much because Dr. Kopp gave a lecture previously. Again, the role of antenatal intervention is really to, this is the only urologic diagnosis for which antenatal intervention is currently considered. The theory is that relief of lower urinary tract obstruction could minimize renal and pulmonary development by restoring normally amniotic fluids and help pulmonary development. Indications for antenatal intervention would include sonographic evidence of lower urinary tract obstruction, like we talked about before, having favorable urinary electrolytes for those who are still studying these things and trying to remember them for their in-services or the boards. I think an easy way to remember this is that basically good kidneys will retain substances such as those that are listed here. They'll reabsorb them, whereas poorly functioning kidneys will spill these substances, so they'll be higher in the urine. It's kind of a useful way to remember that. Simplistic, sometimes makes it easier to remember. Unfavorable electrolytes, their patients are unlikely to benefit. Favorable electrolytes, many will still develop end-stage renal disease. There are better pulmonary outcomes in severe cases, though. I'm not going to go through all these slides today. There are patients that have complications as a result, which I'm sure Dr. Kopp outlined well. Talked about the Pluto trial as well as systematic review of patients that have undergone these interventions. Future directions might include pedoscopic valve ablation rather than vesicoamniotic shunt, so you don't have some of the complications of vesicoamniotic shunt, either through using a laser or other small instruments. In terms of an unanswered question, there's a question of whether there's a better fetal diagnostic marker that could reliably identify those patients that are most likely to benefit from intervention. Is that some sort of fetal urinary biomarker, proteomic, genetic factor, MRI? Are there other therapeutic interventions which could ameliorate the devastating effects of posterior urethral valve on the bladder? Posterior urethral valve is, from a surgical standpoint, has evolved based on technological advances. Pendulum has swung towards primary endoscopic valve ablation rather than supravesical diversion or incontinent urinary diversion. Unfortunately, there's no early predictor of long-term bladder function and continues to remain a significant cause of end-stage renal disease. Our goal is moving these patients to the right. I appreciate your attention today and your participation in this lecture. I appreciate those who have put this together, Dr. Kopp and colleagues. This is a great use of technology that's available to us. I think people have really understood how much we can do remotely, and opens doors for collaboration. So I'm honored to be a part of this lecture series. Thank you for inviting me to participate. We will open up for questions now with my moderator, Dr. Wang. Is going to help out with that, and I'm glad to do that.
So the first question is regarding urodynamics for patients with posterior urethral valves. The question is early urodynamics reliable since patients are still young and would move a lot during the examination?
Yeah, I think that's a good question. That's a good question of a number of different diagnoses. I think we're finding that there is useful information with earlier urodynamics. If you look at the CDC trial protocol for patients with neurogenic bladder secondary to myelomeningocele, earlier urodynamics at 3 months of age is recommended for that. I think that there's useful information that can come from urodynamics. I think one of the caveats of posterior urethral valve is we know that things are kind of improving in some way for a period of time. So the question is, what is the right time to do that? In terms of slope of improvement, we have kind of stated about 6 months in terms of doing urodynamics. There are other patients in which you're really trying to assess what is their long-term risk and should you institute some other intervention. I think we oftentimes will make a decision radiographically or clinically whether or not to start a patient on anticholinergic medication. Many of these children don't need to be on intermittent catheterization right away. And so some people will start anticholinergic medication in all patients. Some will start them in selected patients. Some providers will use alpha blockers to help with bladder emptying. So there is a kind of a trade-off of doing it too early while things are still in flux versus selecting patients that are appropriate for therapies.
Thank you. Next question is related. It's asking, since we know, evolution of valve bladder, is it necessary to keep repeating video urodynamic studies? Is it possible for us to rely on the clinical symptoms instead?
So I think there is, some movement towards that. Different centers use different urodynamics differently. Some will use them as a predictor a proactive approach to trying to prevent renal deterioration. In this circumstance, I think, kind of a combination of knowing what to expect, radiographic findings, clinical findings can dictate when those studies need to be done. We do know that there's substantial changes that can take place as children go through puberty. So oftentimes there's at least in my practice, there's a kind of a break from urodynamics for a number of years. But I typically want to follow those kids after they've gone through puberty and had some of those changes to see how their bladder dynamics are progressing more formally.
Mm-hmm.
Good opportunity for study though.
Mm-hmm. One question, it's do you use video urodynamics as opposed to, just without video urodynamics for initial evaluation and follow-up?
So we typically use video urodynamics for most of our patients with low-dose digital fluoroscopy, especially using a flat plate condenser. There's really low risk of radiation, low exposure to radiation. Obviously, we want to use as little radiation as possible to get the same information following ALARA principles. I think initially, though, it is useful to understand, kind of reflux status, and that's potentially an opportunity to avoid follow-up voiding cystourethrogram. Again, some people will use that as a surrogate for complete valve ablation and really evaluating that. But there have been a number of studies that show that even doing a voiding cystourethrogram can miss important residual valve tissue. So some of that should take into account whether a patient's responding appropriately to the therapies you expect, and if not, do you need to look for something else. But potentially there's a trade-off of not doing a VCUG and doing a video urodynamic study.
Mm-hmm. This is a question regarding resection of the posterior urethral valve. Do you use cold knife resection or hot hook resection or another instrument? I think, yep.
So I have practiced with providers that use all of those different techniques. My preference is using a hook electrode using pure cutting current. I feel that there's good control. I can engage the tissue and really get a sense of when I've resected it completely. Again, I think there's no study that shows superiority of one versus another, to my knowledge, and might be a worthy study to perform. But I think part of it is related to training. I think the one unique circumstance is that for patients that have small urethras because of their age, potentially using something like a 3 French hook electrode or using a laser can be useful as well, just because you can then instrument a smaller urethra without a resectoscope that's at least 9 French.
Another question, what settings do you use for the hook?
As little as possible. Usually using 10 or 15 of pure cutting is fine.
Okay. some more questions about urodynamics. Do you perform urodynamics with a urethral catheter or a suprapubic catheter? And what do you think about this is cystostomy for video urodynamics?
Yeah, so that's kind of, again, one of those areas that I don't think that there's clear literature that would guide superiority of one approach versus another. There are pros and cons of each approach. So doing a suprapubic tube with a dual lumen urodynamics catheter for all patients that are undergoing urodynamics may subject some patients to additional morbidity, particularly if you're doing serial urodynamics over time. However, some patients' bladder dynamics are affected substantially, and anecdotally, performing video urodynamics with a patient with a urethral catheter followed by suprapubic catheter, there are some patients in whom bladder pressure is changed substantially when suprapubic catheter is used. So there's a trade-off. I think you have to interpret the information you get from either study in the context of the way that the study was performed. Small children using a 7 French catheter for urodynamics may have some obstructive component of their urethra that's not related to their anatomy, but of the catheter itself. So kind of have to understand why you're doing the study and what information you hope to get from it. But there are limitations and advantage and disadvantage of each approach. So in my practice, I typically use a urethral catheter unless the information is unreliable in a way that I can't make clinical decisions, or if the picture is too confusing, and then I'll consider placing a suprapubic catheter. Okay. Some institutions use it routinely though.
Okay. Another question: if the VCUG is normal, are you still concerned about posterior urethral valves if there was a prenatal suspicion for that?
Yes, that's a great question. So presented in poster form about 10 years ago, a paper that looked at some of the neonates that underwent, so premature babies that underwent hook ablation with this 3 French scope. We found that VCUG could miss residual valve tissue. But again, this is kind of in the context of what is clinically significant valve tissue. Hardy-Hendren described kind of mini valves as being potentially a pathologic condition, may lead to some lower urinary tract symptoms, but may not cause renal failure. So it's a question of whether or not there's any substantial significance of the residual valve tissue. I don't think anybody knows that well, but there are a number of studies that would suggest that voiding cisterethrogram can miss residual valve tissue if you go back and look for it. And I think that's more often the case in premature infants, in which resectoscope or typical instrumentation isn't used.
Another question related to patients with overactive bladder and a history of valves. Do you use oxybutynin given the concern of potentially affecting the central nervous system?
That's a good question. I think, again, none of these medications are actually probably approved for posterior urethral valve if this is myogenic overactivity rather than neurogenic, which is overactivity. That being said, there are limitations of the more selective anticholinergic medications or medications like mirabegron, which is an M3 agonist. There are dose issues and being able to take medication. The Ditrovan is the easiest to dose with respect to it coming in a liquid formulation. Many of the others are extended release and can't be divided or taken outside of the capsule, so that significantly limits those patients. We know that the patients that are more likely to have hyperdynamic bladders are younger patients, and those are the ones that are going to be less likely to be able to take something other than liquid medication. So it's kind of, sometimes we're stuck by the available medications. It would be really nice if we had more pediatric formulations of the more selective anticholinergic medications.
Another question is, I'm wondering if you could elaborate on your preference for early versus, delayed valve ablation.
Yeah, so if the context of that question relates to my comment about waiting for some degree of creatinine nadir versus just going ahead and ablating the valve, I guess when I speak of nadir in this sense, not truly the nadir with respect to like the lowest creatinine during the first year of life, but typically there's a point after delivery in which the creatinine starts to go down, or it starts to go up, depending on what the impact of the valve is on one's renal function. I kind of like to at least see some stability before I do a valve ablation personally. That being said, I've practiced with excellent pediatric urologists that will perform valve ablation as quickly as possible just to get the catheter out and then kind of deal with the creatinine being what it was. I like a little bit more stability so I know what variable is affecting what change, but that may potentially subject a patient to a longer catheterization, catheter-associated urinary tract infection. So there's pluses and minuses of both, but my preference is to have at least some stability of the creatinine before doing valve ablation.
Okay. I think we've answered all the questions thus far.
I think we can end 3 minutes early. So again, I want to thank the pediatric urologists at UCSF, particularly Hillary Kopp and her colleagues, for putting together this series. Really, I think this is a great use of technology and circumstances in our world that allow us to all get together remotely and do something positive out of an otherwise negative situation. Appreciate Dr. Wang for moderating the session today. We'd like for you to participate further in these lectures. Appreciate you sharing thoughts by taking the survey using the QR code that's on the screen now. Again, this lecture will be recorded and distributed on the UCSF PedsUroFLO website, which is listed here as well. So thank you all very much for participating today. It's my pleasure to do this.